Hi, my name is Josh Brody. I run the Lymphoma immunotherapy program here at the Icahn School of Medicine at Mount Sinai in New York. And just getting back from ASCO 2026, it was a very exciting meeting with significant surprises and some of them extremely important or will be important in the near term for our patients with common types of lymphoma. And if I had to make an common theme amongst some of the great advances that we're starting to see or seeing, it's that we're getting patients' immune systems to get rid of their own cancer, and this is super gratifying for us and for our patients. Maybe even especially for patients, because chemotherapy is a thing we do to patients, giving them some hopefully low and tolerable dose of poison to get rid of cancer. But from patients' perspective, when they get their own immune systems to get rid of their cancer, it feels like they are part of the fight instead of just, a bystander. So yeah, gratifying for all of us that we're seeing awesome results of some new immunotherapies. And if I just give a couple quick examples that were featured at this ASCO, one of them is for a rarer but really not great type of non-Hodgkin's lymphoma, which is mantle cell lymphoma. Mantle cell lymphoma historically has been amongst the worst prognoses of all lymphomas. There have actually been a lot of advances over the past decade and even a bit more. Kinase inhibitors like BTK inhibitors and BCL2 inhibitors, significant advances for mantle cell lymphoma, and immunotherapy advances. Like we have a couple of FDA-approved CAR T cells for mantle cell lymphoma, which have pretty high response rates and pretty good durability. Problem with those CAR T cells is that the side effects in mantle cell lymphoma are even more than the side effects we see with other lymphomas. Cytokine release syndrome, CRS, and Icahns, the neurotoxicity associated with CAR T cells, are even at significantly higher rates in mantle cell lymphoma. So we have a newer, perhaps more accessible, off-the-shelf, and I would say overall maybe safer and easier to use immune therapy for mantle cell lymphoma, which is bispecific antibodies. And we have a CD20 by CD3 bispecific antibody called glofitamab, which has been now pretty well studied in mantle cell lymphoma. So we presented an oral abstract at ASCO just now, showing some of the long-term follow-up, but also a larger patient cohort than had previously been described. So we actually described some of this cohort in the Journal of Clinical Oncology last year. Tysel Phillips was the first author of that pretty impressive study. And now it's, I would say, even more impressive because we have more patients and more time. And the quick punchline is that the response rates of mantle cell lymphoma, and these are mostly patients who have had multiple lines of therapy. Most of them had prior BTK inhibitors and those that stopped working, and sometimes many other therapies. And the response rates were remarkably high, well above 80% of patients getting remissions and more than 70% of patients getting complete remissions. And that is extraordinarily high for multiply relapsed and refractory mantle cell lymphoma. I would say that is, not head-to-head studies, competitive or maybe even higher than CAR T cells, which is kind of extraordinary because CAR T cells we think of as, the big gun in, most lymphomas and other diseases that we use them for. And it might not be totally surprising that these bispecifics are even more effective than CAR T cells if that's the case, because they're going after CD20, whereas CAR T cells that we mostly study are going after CD19. And CD20 is highly expressed on mantle cell lymphoma, even more so than some other B-cell markers. And we also know that because rituximab, the plain old CD20 antibody, has remarkable benefit in mantle cell lymphoma. Mantle cell is one of the only places where maintenance rituximab actually has an overall survival benefit in some contexts. So not surprising that targeting CD20 is especially helpful in mantle cell lymphoma, but still quite extraordinary that the complete remission rates with glofitamab for mantle cell have been as high as they have been. The safety has been pretty good overall, but I don't want to tuck that under the rug because, again, the CRS is higher with mantle cell than the CRS that we see with other bispecific trials focused on DLBCL and follicular lymphoma. The CRS rates were significant. They were single digits for high-grade CRS, but still, in fact, to get them to be single digits, we had to actually take more precautions to prophylax and prevent against CRS. So patients got sort of a double dose of obinutuzumab the week before the glofitamab. Maybe that decreased CRS. And we had pretty low thresholds to give patients extra CRS therapies like steroids, dexamethasone, and tocilizumab, anti-IL-6 receptor antibody. So overall, the safety, I would say, was significantly better than what we generally see with CAR T cells. certainly the ease of use was better because it's an off-the-shelf product. You don't have to make personalized therapy for every patient. So it was a pretty exciting report or update of a prior report. And then I'll give another example of another immunotherapy, which had maybe even more surprise for us because it was the first report. And this was a report of the Frontline study, which was also then published the next day, this past weekend in the Lancet. The Frontline study is adding, let's say, a randomized phase 2 trial for frontline therapy of DLBCL, adding to the standard R-CHOP therapy these novel immune therapies, tafasitamab, anti-CD19 antibody, and lenalidomide. Lenalidomide, we've known about it for a long time and its efficacy in lymphoma. Tafasitamab, previously used in some other settings in DLBCL and follicular lymphoma, but certainly this is the first time we've seen it in a frontline trial for DLBCL and in a large randomized trial. So the benefit we saw adding these two new agents, Tafa plus Len, to the standard R-CHOP was quite significant. The hazard ratio, the improvement in progression-free survival was 0.75. So, 25% of the patients in some sense were doing better with the Tafa added on top of R-CHOP. And so that's pretty good. It's not an overall survival benefit yet. It's a PFS benefit. There was a little hint towards improvement in overall survival. I got to say, the thing that was sort of impressive to me, it was that adding Tafa and Len on top of R-CHOP, I thought it was going to add a significant amount of more cytopenias and more infections. It added only a little bit. There was sort of a 3% bump in high-grade infections. That's actually 3%, not that much. So by comparison, the Polarix trial a few years ago added polatuzumab on top of standard of care therapy, and that added like a 6% bump in high-grade infections, which was surprising because polatuzumab's pretty gentle. So I was sort of delighted and surprised that the addition of Tafa-Len still kept the frontline therapy pretty safe, so that most patients were able to receive the full therapy, and again, overall have this improvement in staying in remission. So that's a significant benefit. Honestly, that would probably lead to an FDA approval of that regimen sometime this year, hopefully, and I think it'll get some utilization. The context is that we already had this other randomized trial, Polarix, which had a benefit in PFS now a few years ago, and the proportion of people using Pola-R-CHP instead of R-CHOP is sort of variable. In academia, it's used quite a bit. In the community oncology setting, it's used somewhat. And the tricky thing about that trial is that we really saw most of the benefit of the Pola-R-CHP in what we call the ABC subtype of DLBCL. They got a lot of benefit. While that whole trial had a hazard ratio of 0.76, that subgroup got a PFS hazard ratio of something like 0.5 almost. So there's a lot of benefit in the ABC subtypes and almost no benefit in the GCB subtype. With the new Frontline trial, it doesn't appear to be the case. All the patients seem to get a benefit. So we get a lot of questions, how will we incorporate this great new result, this improvement in outcomes for patients? And the answer is that there's no single answer. I would not be surprised if some academics incorporate this into their practice by saying, well, if possible, maybe we should still be trying to give Polarix type therapy to the ABC subtype patients and frontline therapy to the GCB patients. That's not the right answer because there's no head-to-head there. But it wouldn't surprise me if that shows up as an SOP, a standard operating procedure amongst some clinicians. And the even more complicated part about this frontline DLBCL setting is that, we had really 20 years of trying to beat R-CHOP and just failing and failing over and over again. And now we're going to have the other problem, which is we're going to have multiple successes. That is the good problem to have, is multiple successes. But in addition to these two recent successes, Polarix and the Frontline trial, we expect the results from another recently completed trial, which is called the EPCOR DLBCL-2 trial. It's a pretty simple layout of just taking R-CHOP and adding epcoritamab, the bispecific antibody, on top of R-CHOP versus R-CHOP alone. And we expect results from that trial pretty soon. And I think the common consensus is that the expectation is that will probably be a positive trial. And the reason is because epcoritamab on its own is a pretty potent agent in DLBCL and overall pretty well tolerated. So that frontline trial, if that results in the next few months, we're going to have a lot of complex decision-making in the front line. And it is a good problem to have because all of these things seem to be finally improving on R-CHOP, the thing we were struggling to do for decades. and really some innovation, and specifically getting the immune system to kill lymphoma cells has resulted in this good problem to have, this excess of new ways to make patients in first-line DLBCL, the most common type of lymphoma, be more likely to stay in remission for longer and hopefully be more likely to be cured. So we're waiting to get those data soon, but already at ASCO 2026, we saw a lot of change in already the standard of care coming up for the most common type of lymphoma. So very exciting results.